Bene, buongiorno a tutti.
Good morning, everybody. I'm happy to see a lot of people still sitting here in the room, also because we're going to watch another interesting surgery to be performed by Dr. Alessio. And so I wish, first of all, to congratulate all surgeons on the marvelous procedures, also because this shows us that life surgery, even though the case is difficult and tricky, if performed by such experienced surgeons, is extremely successful, and we've checked this on our patients, because we should always remember that at the end of the day what really matters is the final outcome of the patients. So keratoconus, and topography. So a very nice study was published by authors, some of whom are still here with us, about this topic. So groups of ectasic diseases or entities were listed, so keratoconus, so PMT, so marginal pellucid deformations, keratoglobus, and post-refractive surgery, progressive corneal ectasia. So the first two entities, actually they're not really entities, different entities, but they are different forms of the first of the same entity. So what really matters is that this study has also recognized the relevance and importance of topography, that is to say the study of the elevations of the posterior and anterior surface and the pachymetric maps. And this has shown that OCT and topography may really diagnose, and tomography, and OCT may really help us diagnose more accurately an early keratoconus, whereas this does not, what is not included as ectasia, but is only a thinning disease, Terrien marginal degeneration, Dellen, and the inflammatory melting. Why is it so important to put a correct diagnosis, but also to study in detail the keratoconus? Because until recently we only had a couple of possible techniques to be used, like PK and contact lenses. We have seen, also based on some very interesting papers that were presented today, that nowadays we have now many more weapons in our armamentarium to be used at the right time, in the right way. For instance, as the cross-linking in all its variants, the customized minimal PRK, DOC, and why not also the toric IOLs, so phakic IOLs and toric IOLs, why not? And all this may really be used and resorted to by us. So that's very important. Every time we have to, or we consider a surgery, we should study a number of elements. So first of all, we have the clearness and the transparency of the cornea. So otherwise, the surgery will have to be partially or totally substitutive. For instance, a PTK or a DOLC, depending on whether there are stronger or mild hazings within the cornea. And the second point is the localization of the cornea. How distant, how far apart is this cornea compared to a normal cornea? Because the more distant, the more difficult the surgery, of course. And then, last but not least, where exactly ectasia is localized. So here we are all agree this is an early paracentral keratoconus, and we have the three parameters, so the ectasia on the anterior surface and minimum thickness point. And this is clearly a conus which may benefit from a highly conservative procedure if it is keratoconus only, CXL, otherwise a minimal PRK, or the implantation of stromal rings. And this is a different situation. Here the morphology of the cornea is completely deformed compared to a regular morphology. So no conservative treatment is possible. So most of the times we'll have to think we'll have to consider, however, a conservative treatment, but however replacing the majority of the stroma, so lamellar keratoplasty. So this is a very reduced thickness, especially at the center, so the cornea is strongly altered. So here it's obvious that the treatment of choice will be surgery and with a lamellar surgery. So when the keratoconus is there, but there is the toric nature, so the toric shape is quite irregular. These cases may be treated with eyeglasses in order to, and followed up in order to see whether there is a progression or not. So that's an instrument that allowed us to understand where ectasia is located, because at the beginning we only had tangential and axial localization, but we didn't know exactly where the ectasia was. So this study has been made possible with altitude maps, and so we may decide a lot more than we could in the past. For instance, the diameters. Yesterday with Dr. Galano we have been studying in detail the thickness maps, because you know that pachymetry should be carried out not only on one point but on a map. And this way we can choose the most suitable surgery. Here we have an early keratoconus, but which is thin all the way, and here we have 10/10, but the cornea is centrally very thin, less than 380 microns, but the visual acuity is very good. So this is a conus that sets on an already thin cornea. So these renderings, we might say, or maps really allow us to make the best choice. Let's now turn to a particularly interesting ectasia, so the marginal pellucid degeneration. So what is it? So this is a peripheral ectasia that has to satisfy and meet three criteria. First of all, the most of the ectasia should be located at the periphery, but also the thinnest point should be located at the periphery. So a fourth criterion is necessary, clinical, it is to say, at a slit lamp there should be a thinning. And so this tool also allows us to study the 8.5 peripheral millimeters, and we clearly see where the thinnest point is located here. And this then may be confirmed by the slit lamp. Why is it so important? Because we do have PLK cases, so pseudo-pellucid cases, presenting with a similar look. So we have a peripheral ectasia on the two surfaces, but at the center we have the thinnest point. So topographically is similar, tomographically also, but not pachymetrically. So here we have only two criteria made. So why is this interesting? Because it looks like a pellucida, exactly like a pellucida, and that's how it was diagnosed. But actually the thinnest point is located at the center. So why is it this relevant? Because whereas the pseudo-pellucida cases have a very good solution by implanting the intrastomal rings. In the true pellucida, the intrastomal rings are actually contraindicated, and here you have all the necessary data. To conclude, an interesting piece of data. So the follow-up should always be considered. This in 2011 looked like pellucida after 2 years, a pseudo-pellucid, then after 3 years turned into a true pellucida. So there is still a lot to be understood. We don't know whether the pseudo forms over time may turn into true pellucida forms. So do I have any time left? 0 seconds. Anyway, this is a case that I have seen very recently. It's a 65 years old lady that had been followed up for quite a long time because due to a keratoconus. But I suspected that this might be a furrow degeneration. What is it? That's a very rare degeneration where you have a thinning in between the limbus and the senile arcus. But there is here you may see the various definitions, and look at the two eyes of this patient. This looks like a central conus, but from a topographical viewpoint, also the fellow eye looks the same, but at the tachymetry, this eye is really weird, two very thin points, one at the center and the other at the periphery. And believe me, there was actually a thinning. And we desepitalized, and there was a very clear-cut demarcation line between the healthy cornea and the peripheral cornea. So it might very well be conus plus furrow degeneration. So, in conclusion, always tomography to make a diagnosis and following up keratoconus over time, especially when the diagnosis